I'll go ahead and start us, since you're here, Dr. Wilson. Love the term hypervaccination. That's great. Do you get questions about the impact of daily antibiotics on diarrhea, or people using the term gut microbiome, which is not my favorite area of study, but I wonder if you could comment on that.
Yeah, I got that question Wednesday. Had a long discussion about that. It happens. It's an antibiotic. The gut microbiome is real. We are interrupting it by using daily amoxicillin prophylaxis. Again, it's I haven't had it to where the quality of life makes it so we're coming off of antibiotic prophylaxis, but it's a common conversation that I have with patients that, and again, as most things that we do, it's shared decision making with how much is quality of life adjusted by that.
Awesome. That's great. Thank you.
I have a question. For our youngest and most vulnerable patients, I guess what is the conversation or the framing they have with parents about using breast milk or even donor breast milk to help get some of the maternal protection while they're too young to get their first set of vaccinations?
That's a great question, and I'm not sure I've had that conversation in the setting of heterotaxy, but I think it's an important one. We know that those outcomes are better, and it's just not, I'm not usually in that neonatal period when we're deciding to breastfeed or not. I feel like I usually come in a little bit after that, but I do think it's an important point, and I don't know that there's strict guidelines or even recommendations that say that we should be thinking more about that in our heterotaxy population.
So I had a question about the pitted red cells. So it looks like if they're low, you repeat them. But if they're normal, do you still feel like, as you're following them, that you have to repeat these over time?
You're referring to the IgM memory B cells?
Or
The PITs.
Yeah, or
Right.
either one of those maybe.
Right. So what I would say is that for asplenic patients, it really doesn't make a whole lot of sense. But what I've been seeing with the hyposplenic patients is the first thing I want to know is there evidence of hyposplenism or not? So obviously, if there is hyposplenism, then we need to treat those patients accordingly. So then the question is, what is the time course, or what is the long-term outcome of these hyposplenic patients who have polysplenia? And that really isn't well understood, but we're seeing the data, like we talked about just a few minutes ago, that can change over time. Spleen grows up into adolescence, so it may be that some of these patients with polysplenia and hyposplenism over time may develop adequate splenic function to keep them protected. So I think that's an area of research that'll be helpful for us to look at.
I was just going to say, too, there's not a lot of data about this, but there is a documented immune system immaturity that you can see pitted red blood cells in normal infants. And so I don't think we know fully how that works. So I do think, the test is really not validated under 6 months of age. And so we have to act accordingly to protect our patients, but it should be reevaluated over time because maybe their splenic function is normal.
Go ahead.
This is a terrific session. It's so great to see folks from immunology and general surgery engaged with the heterotaxy population. I wanted to shift gears for a sec to ask about biliary atresia. And if I may, I'd love to share an anecdote, which would take all of 45 seconds. But one of the first patients I cared for coming on faculty at Boston Children's was an individual with a hypoplastic left heart variant who underwent his stage 1 Norwood, and it wasn't until 6 weeks later when we saw jaundice in the bilirubin rising that we were able to identify biliary atresia. So it was a very humbling experience, and now we routinely screen with direct bilirubin. So hopefully helpful to share that. My question really is related to prenatal diagnosis. I would say around 3-4 times a year in our prenatal clinic, we identify heterotaxy polysplenia phenotype with the only cardiovascular abnormality being interrupted inferior vena cava. And from a cardiac perspective, in general terms, we're saying, you know, outlook is terrific and really not too many concerns, but there is that nagging voice in the back of my head that wonders about biliary atresia, and it is something that we speak about with families. So that's a long way of asking this question, which is there a way to identify it prenatally?
Prenatal ultrasounds can show the cystic variant of biliary atresia, which is pretty rare. It's less than 5% of the cases. But outside of that, it's really hard to diagnose prenatally. So I think particularly for this patient population, getting that fractionated bilirubin when the baby is born, especially when they have, you know, either prenatally diagnosed laterality defects or congenital heart disease, is going to be the best test.
It's super interesting to hear that some of those liver changes occur before birth. So thank you.
Okay, hi. Thank you for taking on some of the highest yield and highest risk issues in heterotaxy, yet also are faced with the greatest level of uncertainty for how to screen and how to manage and how to diagnose. So we appreciate you taking on this very difficult challenge, the four of you. So vaccines in heterotaxy obviously are critical because people can die from fulminant sepsis. Yet it seems like in this country there's been a massive trend towards greater vaccine hesitancy. That's gone way up the ladder to the CDC and the AACIP, and I won't get into politics today at all. But what I'm trying to say is, when is it the right time for a medical organization like us, for example, to issue a strong statement? Not that we're issuing formal recommendations and requirements for the rest of the population, but when do we reach that level at which our organization needs to take a proactive approach at maybe counterbalancing some of the population hesitancy and maybe even miseducation towards vaccines?
I think that one's for me. You know, of all the things I worry about with vaccines, that's certainly one of them. You know, I am lucky that I think I have the time to spend with my personal patients to talk about how important this is, and I have never to date had, I have many people that don't like vaccines in my practice in other situations, but in these, that's never been a tough sell. I think the data sort of speaks for itself in terms of risk-benefit here. I do think my concern is more for the future, actually. So, you know, I showed some data that said that there is strain replacement in pneumococcus. We know that that happens. And as we limit data, or as we limit, you know, research money for developing new vaccines and putting less emphasis on the need for new vaccines, I think our future patients are suffering. So that's where I think that we should advocate is money for future vaccine development. And yeah, I don't know if that answered your question.
Yes, thank you.
And the effects that it might have on herd immunity, right?
Absolutely.
Yeah, So-
I just have one final question. This is about the ultrasound screening of volvulus. The fluid, is that some kind of special fluid or any feed or water, or is there a special contrast that they're using?
No, I think just any fluid.
Any fluid, okay, so that's really nice and convenient.
It just helps distend the duodenum so you can see it better.
Yeah, okay, we need to learn more about that. Well, thank you all for, oh, we have one more question. Go for it, yeah.
It might be
Great.
a quick one, but Chris Mathis from Kansas City. But regarding malrotation for, I guess, for either general surgeon, for patients with heterotaxy who are undergoing evaluation for G-tube placement, regarding dysphagia, what are you looking at or assessing kind of in terms of considerations for like concomitant LAD procedure in those patients? Is that, in your mind, is that kind of a knee-jerk reaction to assess for LAD bands during G-tube? Is that, does it depend on kind of the reasoning for G-tube?
Yeah, I think it depends on the symptoms. Is it clear, just like, okay, the kid tolerates G-tube feeds, is doing well, and by the way, but is really tenuous and limiting the anesthetic is the best sort of thing for this kid, so doing a 15-minute G-tube and getting in and out quick is probably the best thing. Then that may be a kid where you may just get into a G-tube and not spend too much time looking for things, right? But I think it's a kid that is like not tolerating gastric feeds, intermittent vomiting. That question's always like there, right? Is the reason for that request for post-pyloric feeds or GJ feeds because there's obstructive bands of the duodenum? I think that's the one that you probably ought to do. And many times just looking at the chest, the X-ray, the belly X-ray, you see where does the NG tube end or where's the feeding tube end, and you can kind of get a sense sometimes from that. But I think those are the kids that maybe ultrasound or just intraoperatively spending a few more minutes looking for that. It may be worthwhile, but you sort of have to counsel that I think going that LATS pathway does add maybe 45 minutes to potentially an hour, depending on how the exposure is. So it does add a little bit more time in a child who may not be totally symptomatic. It does. That's probably why we see some increased risk and complications when those were done across the board. But I'm curious to see what they do in Texas.
I agree with everything that you said. I think I've found myself in a situation many times where a kid was tolerating gastric feeds and had rotational anomalies, and then intraoperatively saw some adhesions that weren't symptomatic. And then you're like, well, am I going to help this kid if I do something about these? And I think you just kind of have to consider them on a case-by-case basis. What I typically counsel families about more often so is, particularly if the stomach is not in the normal anatomical position, where that G-tube is going to be sited and how that could change things, especially if the liver and the stomach are on the same side, then G-tube, it's got to reach. And so that can be really challenging and cause some other issues in terms of the way the stomach drains and things like that.
All right, well, yes, one more. Great.
Just because I can see there's a little bit of time, I always
Yeah,
hate to
absolutely.
be
Yeah.
person holding everybody up. Thanks again. I actually have a particular interest in portosystemic shunts, and I was wondering if some of the panelists could talk about how you guys deal with portosystemic shunts, like evaluating for them, treating them at your centers. As an interventional cardiologist, I actually do a fair number of them with us, but I work really well with our liver surgeons. And as a side note, that came about just from helping them with hepatic vein outflow obstruction, right? So I just ended up kind of serendipitously having a good relationship with our liver surgeons. But I was just curious how you evaluate for them, because specifically in a lot of these polysplenic heterotaxy patients, they're very hard to identify.
Where I trained at Vanderbilt, we had a pretty large series of congenital portosystemic shunts, and a lot of those kids were intervened upon either with a combination of interventional radiology and the transplant surgeons. At Dallas, I haven't really seen that since I've been there. I know that Dr. Superina at Chicago, he takes care of a lot of those kids, but maybe you're
Same here. I haven't been involved in that aspect of the care of these patients. I do think, Dave may know a little more about it, but there has been some that we have collaborated with again, also our transplant team and the interventional cardiology component. So,
yeah, we seem to have had a run in the last several years. I would say we've probably had 6 in the last 3 years. We've had 2 banded in the last year by our transplant surgeons. HB Kim has done them. And it's been pretty eye-opening to see sort of their criteria, what pressure he would band versus occlude. It's crazy. Yeah, I know. Yeah. So, but it's, I think it's super important to find. We actually, a patient of mine earlier this year had AVMs by 7 months and already had pulmonary hypertension after a complex biventricular repair where the portosystemic shunt is now banded. So I do think it's an important element, and you really have to be aggressive about treating it before you get behind the 8 ball.
Just my little bit of a plug, because the same thing happened with me, again, just serendipitously. I suspect they're a lot more prevalent than there's actually some publications from Boston. One of my old mentors looked it up, something like 20% of the kids have them, specifically with a polysplenic variant, and I think just surveilling for them is important. Yeah. And then treating
And then
them.
doing something about it, yeah. But early, I think early cath and really understand the hemodynamics and abdominal imaging and MRI, and I think there's a place to go full Martin.
Any other follow-ups? All right, well, thank you very much to our speakers, and thank you for everyone else for your attention.